I think it's great that the vascular community has come together in so many different ways, including around some of the work that I've been part of, and so I think it's a great celebration of all that we've achieved together. Well, I think first we're lucky to have now data from some large clinical trials to help guide practice. The ATTRACT trial has published some additional sub-analyses. The results of the CAVA study, led by Case Wittens, were presented earlier this year at the American Venous Forum. And then we've also seen increasing use and experience with some of the new devices that are out there to treat acute clot. The CAVA study looked at patients with acute iliofemoral DVT, and really the results were very similar to what we saw in ATTRACT for that particular subgroup of patients, specifically that providing acute thrombolytic therapy did not reduce the occurrence of post-thrombotic syndrome. In the ATTRACT study, we found, however, that there was an improvement in quality of life in the people that were treated with thrombolytic therapy, especially in the first 6 months, and a little bit less so in the long run. But overall, the two studies were pretty similar in showing that there wasn't a benefit in PTS prevention. Well, I think that it's pretty clear that in the short term, for patients that are particularly symptomatic with their iliofemoral DVT, they can't, for example, walk very easily without severe pain and swelling, that using thrombolytic therapy does improve pain and swelling early on and improve their quality of life in the first 6 months after treatment. However, beyond that point, the degree of benefit, some people may experience it, but some may not. And so now when I talk to a patient, I overemphasize the short-term benefits and I underemphasize the long-term potential benefits. There's certainly increasing interest in using thrombectomy alone without the use of lytic drugs, and that continues to be an area of interest. We would love to be able to reduce the occurrence of bleeding. At this point, there isn't a clear-cut solution in terms of being able to do that. There are clearly some patients, particularly with large volume clot that formed in the last several days, for example, where the use of a thrombectomy device can substantially debulk the clot and enable an effective treatment, at least in the short term. But we don't really have any long-term results. There haven't been any really high-quality prospective studies to look at the device alone type methods. The open vein hypothesis refers to the idea that if you remove clot up front in a patient with an acute DVT, the patient's health will be better in the long run. Dr. Ida Weinberg collaborated with the ATTRACT investigators to study this specific question, and what he found is that when patients have an open common femoral vein and iliac vein 1 month after treatment, then they're less likely to develop post-thrombotic syndrome and more likely to have better health-related quality of life. That demonstrates really that the open vein hypothesis does have some validity. On the other hand, it's clear that there are other mechanisms at play as well. Well, I think what's most important to look at the patients with iliofemoral DVT and really try and discern to a much higher degree which patients benefited the most in the clinical trials that have been done and which patients don't benefit as much. We have some sense that people who are very elderly don't benefit as much. We have some sense that people with more symptoms when they initially present may be the best candidates, but it would be better to get better data to really work that out so that we can offer the treatments to people who really need it and provide that benefit to them.